everyone, and thank you for joining today's virtual presentation as a part of our 2021 Global Health Leaders Conference at Johns Hopkins University. I'm Siam Rezwan. Today, we are honored to have Dr. Habibul Ahsan at our conference. To briefly introduce Dr. Ahsan, he is Dean of Population and Precision Health at the University of Chicago Biological Sciences Division, Director of the Institute for Population and Precision Health, and Lewis Block Distinguished Service Professor of Public Health Sciences, Medicine, and Human Genetics. Dr. Ahsan's research interests focus on studying the interrelationships between environmental and genomic factors in cancer and other diseases, and exploiting information on these relationships at the population level in developing and evaluating prevention interventions in humans. Dr. Ahsan, we are very grateful to have you at our conference today. Feel free to begin your talk whenever you're ready.
Rezwan, thank you, Siam, very much for your inviting me, and I'm delighted to be here. And thanks. I see a lot of students are on the call, so I thank all of them to take time on this Sunday morning to get exposed to some of this work that we are doing here at the University of Chicago. So as Siam mentioned, I am the director of Institute for Population and Precision Health at the University of Chicago. And what I will do today, I will be, I looked at the previous topics that have been covered in this seminar series, and I saw that the global cancer research was not one of them. And our institute does research in a variety of areas, but I wanted to, and those are listed here, as you can see, but I decided to talk about cancer given that this topic has not been covered here. So I thought it would be good to give you an exposure on that, especially from a global health perspective. And because cancer often is not, is on the top of the radar when it comes to the global health concept. It's mostly infectious disease, nutritional diseases, malnutrition, and including now COVID disease, COVID-19 disease. So our Institute for Population and Precision Health conducts research in variety of these areas. And as I mentioned, I will cover some cancer research that we are conducting in the global health context. And feel free to ask me questions. And I will try to leave at least 5-10 minutes at the end to answer any questions that you have but you are welcome to interrupt me if there is any pressing issues that you want to feel clarified. And what I thought I will do, I'll give you a brief introduction because you may or may not be exposed to some of these terminologies that even if our institute has precision health. So I'll give you a little introduction of that within the context of global oncology. And then I personally am a physician, but trained in epidemiology. So in case you have not been exposed to epidemiology by now, I hope you are. So I'll give you a little bit of exposure to you, the key tools in terms of research design and statistics that we use in epidemiology in medical research. I'll just give you a little brief exposure to that so you know what's the key bread and butter in our day-to-day life. And then from the context of global health research, I will give you a little introduction to what University of Chicago's Global Health Laboratory. We have been using this laboratory in Bangladesh over the last more than 2 decades to do a variety of global health research, including cancer. So I'll give you a little exposure of that. And then I will end with a couple of brief overview of I picked 2 of our studies, research studies that we have been conducting within that context in Bangladesh, Chicago Global Health Laboratory. One is a cancer prevention clinical trial, and another is a more recent investigation of application of artificial intelligence in cancer research within the context there. So those would be 2 brief introduction as an example of what we are doing and what can be done, just as a flavor to you, okay? So with that, let's start with, as I mentioned before, I'll give you the concept of precision health. So, I put medicine on the top. So think of this is what medicine used to be 50 years ago, so everything within the domain of health now there was part of medicine, and that used to be taught in the medical school setting. And whether you mean health policy or taking care of patient or doing mechanistic work in the laboratory. Everything used to be in medicine within the medical school domain. Then about later on, in like about maybe 40, 50 years ago, the concept of public health came within the concept of medicine, and slowly over time, over the last several decades, public health became somewhat separated, even if it's part of the medicine, but it has not, I shouldn't say separated, it became an independent domain. And schools of public health have been established. And for example, there are many, including Johns Hopkins and many other places, there are schools of public health. So there is School of Medicine, that's School of Public Health. So the public health, as you can imagine, this deals with the health of the population as a whole, and medicine primarily taking care of the patient and one patient at a time. So that's what happened over time. And very recently, I would say probably the past 10 years, medicine became even more super specialized, meaning more individual focused, which is somewhat away from public health, as you can see. And the concept of precision medicine has been coined, especially within the context of cancer and other diseases. And this is what it means is that, it came mainly from the treatment part of the healthcare. So the concept came that not everybody responds to treatment the same way for a given disease, for a given treatment. So every individual, as you may know, if you take Tylenol for your pain medicine, not two of you will have the same level of alleviation from a Tylenol you take for headache. So there are individual variability because of our genetic composition, because of a variety of other factors. Those dictate how well someone responds to a therapy for a given disease. Okay, so that's why this concept of precision medicine came, which is geared towards individualizing or personalizing therapy based on who you are. Okay, so that has been happening over the last decade or so. So, and as you can imagine, so now already medicine used to be a one big picture before more, because that's what you, and then over time, public health became a little bit somewhat independent entity, and medicine became even super focused on an individual level, became precision medicine. So there has been somewhat, and that led to the, there are many other factors, but this is even exacerbating or widening the gaps between an individual getting help from medicine versus the whole population getting help from medicine or development in medicine. And because in medicine is becoming individualized level, and to the point that many of these precision medicine concepts, therapy, and those are expensive. Not everybody in the population have access to most recent, up-to-date, most modern medicines. So that is now conceivably widening the gaps between different populations who have access to good medical care versus who don't. And so again, so that's what led to the conceiving our institute, that I, being a physician and public health trained expert, I conceived this idea of institute that will try to merge these apparently diverging disciplines in medicine, that is widening the gap between individuals who have access to medicine and who don't good care of medicine, to bring them together. In other words, we want to preserve the modern discoveries of personalized medicine, but how can we make personalized medicine, which is the best possible care you can have, for everybody in the population. So that's what the goal of our institute. And there are many challenges to that. It's not only, there are something conceptual, something theoretical, the way the research is done, the way the healthcare is delivered and the context, the social determinants of health, and geographic regions and country by country. Not every country has the same scenario. So that's what, but we are trying to take this challenge in merging, bringing benefit of precision medicine to a populational health level. Okay, so with that introduction in mind, let's go to the topic of global cancer research. And I deliberately will today focus on not on the many work we do in Chicago, but mostly work we do in the global context. So you probably, many of you have already been exposed to the various challenges of global health research, especially if it is done in a resource poor setting. As I listed here few of the challenges. You can well imagine, when a resource poor setting, when you have poorer infrastructure, including healthcare infrastructure, the conducting biomedical research or public health research is difficult. And there are many other challenges I listed here that makes it difficult for conducting good quality research in a global health context. But what you may not have been exposed enough, or many of the experts may not have talked to you about, is there are also some unique advantages of or opportunities, as I listed here, for doing global health research, including cancer research here. It's not just cancer, for anything in doing in a low research or developing country context. And that I have listed few of that we have experienced over our last 2 decades of work in Bangladesh in a variety of health disciplines, that we can actually do certain things in a global health in an international setting that are more challenging to do here in the Chicago where I work primarily. Okay, so I just listed here a few. You can read them all, but I wanted to make sure you take this message that doing research in a global context is not always challenging. There are also unique advantages, and if you can leverage those advantages, you can make a big impact. Those of you who would like to go to in medicine, and particularly in global health, as part of your career, you can leverage certain traits there and make a much bigger impact on saving people's lives than you otherwise you think you can do in otherwise. So I wanted you to take home this message, and I can elaborate that if you have questions later on specific aspect. So some quick introduction to the magnitude of problem of cancer, since we're talking about cancer today. As you can see, this is a prediction from American Cancer Society. Dr. Thune is an American Cancer Society senior researcher. So he made an estimate of number of cancers, these are expressed in millions in a pie chart over time globally, okay? And as the light gray is the area where there are low and middle income countries, and the dark gray is the high resource countries, including US, Western Europe, Australia, New Zealand, okay? And as you can see, over time, bulk of the almost 2/3 of the cancers happening globally in another 3 decades will be happening in the low and middle income countries, as you can see. So cancer, first of all, is not only a dominant disease of developed world, and it is already a major health problem in the developing country. The developing country has many other health problems, but they are not immune to cancer. And as more and more inroads happening in overcoming death in the early childhood from malnutrition or from infectious diseases, people are living enough to face the problem of cancer for various reasons. I will not go into the details, aging, other characteristics, environmental risk, many other factors. But the point here is cancer is a major problem, and it's increasingly becoming major problem globally, and we need to pay attention to that. And how can we pay attention to that? This one is showing this is a report from World Health Organization showing that amount of dollars invested in various, in various diseases globally, okay? And particularly in this case is developing world. And as you can see, they put 3 major dominant infectious disease killers in the developing world. as you can see. And so these are the number of lives lost in deaths in millions for the 3 dominant infectious disease and cancer. You can already see majority of the deaths happening in the developing world are due to cancer, which is more than the combined all other causes of infectious diseases, including TB, malaria, and HIV. Okay, whereas the dollars are invested for tackling these diseases are almost minuscule in cancer compared to other diseases. Of course, these diseases deserve major attention, and so are deservedly they are getting it, but somehow cancer still is not on the radar for people who are in the policymakers or who wants to invest in this area. So the point up here is, again, giving you the message that cancer is a dominant problem, is going to be more and more dominant problem, but right now it does not have enough attention, and that deserves more attention in terms of in terms of academic scholarship, research, and resource investment, as you can see. Just a quick overview of the magnitude of cancer worldwide. These ones showing the incidence and mortality of cancer. This one is combined both men and women, and this one is only men, and the bottom one is only women. Okay, and each of these pie are different sections of the pie are different regions of the world. So as you can see, again, another way of showing it, and I'm just mentioning here now, I'll come back to that a little bit later here. The incidence here means, those of you who don't know, number of newly diagnosed disease, in this case cancer, in the per unit of population. And in this case, it could be expressed as per million or per 100,000 people. Whatever the denominator you fix, what's the number of newly diagnosed disease, in this case cancer, in this population, that's the incidence. And mortality is similarly number of death happening from a disease, in this case cancer. Again, the denominator is some unit population size. It could be million, 100,000, whatever it is. So similar way are expressed with the same denominator, but with the 2 different numerator. One is newly diagnosed number of cancers. These are the number of deaths happening from cancers. Okay, if you express that way, this is what you see. Green is mostly Asian countries, and this purple, light purple, is in the Latin American, and yellow is Africa. As you can see, 3/4 of cancers happening in the largely Asian and other low resource countries, African, and about 1/4 them are happening in the developing countries, again, Europe and other developed country. And if you look at the men and women, again, similar. But across the board, if you look at these mortality numbers, as you can see, these proportions are even greater in the developing world than if you look at the incidence of the cancers. Do you see this point? And both in men and women, on the both of this, on the right side, the pie for non-blue is bigger across the board than the left side. Main point is, even if the denominator is same, the number of cancers that is diagnosed in these countries versus number of deaths happening from those diseases, in case of cancer, are even disproportionately bigger in the developing world. And we'll come back to that. Okay, so keep that point in mind. If you express this way, this is what you see. And this slide ranks the top number 1 cancer across the globe by different geographic regions. And top 1 is for men, bottom 1 is for female. And this is, again, the incidence is the number of cancers, newly diagnosed cancers. That's what it's showing. As you can see, more or less across the globe, prostate cancer is the most frequent cancer in men. Breast cancer is the most frequent cancer in women, except some regions where there are cervical cancers are also number 1, particularly in some parts of the Africa. And in terms of men, everywhere in the world, more or less, except for Russia and China, lung cancer is the most common, but prostate cancer is the most common in men. As you can see on the top in terms of incidence. If you look at the same thing in terms of mortality, now the picture has changed. In men, prostate cancer is not the #1 dominant cause of mortality on those same countries that you saw before, including even, and lung cancer is not the top cancer of mortality. And the lung cancer remains the top, even in Russia and China, but rest of the world also, prostate cancer is shifted down, and lung cancer is the #1 cause of death in men. Similarly, in women, breast cancer remains the #1 cause of death, but not everywhere, particularly in some of the developed countries. Now you see lung cancer is the #1 cause of death in female. Okay, the point here is that, again, if you express the number of death per unit population size, the denominator is same, then situation shifts. And I wanted you to pay attention to those, how these graphs are created, what the number expressed, and what is the exact quantity, what's the numerator, what's the denominator. Based on that, when you look at the graph, many different ways to make a point. But when you make a point, when it comes to the disease rates, you have to pay close attention to what it is exactly plotted. And that will tell you what the person is trying to show. And often it is misleading. Often someone can make a point that you may not get it, or you may get a wrong impression. So I just wanted to sensitize you as you are, like when you do your own graph in your science classes, pay attention to the units and the attention to the details of what is the x-axis, what is y-axis, what's there, and in order for you to truly get an appreciation of what is shown and you understand what it means. So that I'm just reminding you of this basic principle, even in when you look at the medical literature, medical graphs and figures and those aspects of it. One last slide I want to show in terms of, and that to make that point another way, is one way the gaps in cancer survival, okay, is expressed from this crude, simple incident mortality data. The reason I'm focusing on this because in a global scale, or in many countries, the cancer data are not collected very details in many formats. So, but at least number of cancers, number of death from cancer, those numbers are available, okay? So from there, you can get a sense, as you can see, this is the ratio, the y-axis here is ratio of mortality to incidence rate, meaning number of death, sorry, let's keep shifting, number of death from a given cancer to the number of newly diagnosed cancer. If you take that ratio and express that in the y-axis, this is, and then you look at the across x-axis, very many different countries. Left is the least developed country, right is the most highest developed or most highest income. As you can see, that ratio keeps going down for most of these cancers listed here. And the point of me showing this slide is that if you look at this cancer, breast cancer, colorectal, prostate, cervix, thyroid, testis, lymphoma, leukemia, many of them actually are reasonably highly treatable cancer. That's my understanding in this country or in the developed world, okay? And currently, a lot of development have happened in these cancer treatments, so their survival is quite good compared to 10, 20, 30 years ago, okay? However, that benefit is much more lagging in the low resource setting. They are still not getting that benefit of good treatment for breast, prostate, colon cancer, and good screening tests, colorectal cancer, breast cancer, mammography, prostate cancer, PSA screening, colorectal cancer, you can do colonoscopy. There are many variety of way you can detect cervical cancer, you can do by pap smear, there are other tests. So many of these cancers are easily diagnosable and good treatment available. However, the benefit of that is have not reached the low income countries as of now. So that's the point here. I'm showing it to you here, if you express this way. And that's another take-home message for you just to keep in your mind. Now I will switch gear to some basic, bread and butter of epidemiology, what we deal with in a day-to-day life. We, as an epidemiologist, we design research studies to answer biomedical research questions, okay? And there are many different technical types of research studies that we do. You may have known many of them, those of you, some of you are at least heard of this terminology, but they can broadly be divided into few categories, okay? One sets of studies are done in the lab, wet lab. When I say laboratory, I mean wet laboratory, where you basically do pipetting and do studies there in a wet laboratory setting. Most of these studies are done in a mechanistic context. Those are taken some parts of the body's cells or fluids, whether it's human or animal, and then you do studies to understand disease mechanism in the laboratory. And by the way, just to clarify, I mentioned that here involving primary data. The biomedical and health research could be done involving secondary data, existing data that is collected for other purposes. And most of those research fall into the, like when you do health policy research or other type of cost effectiveness research, for example, health economics research, you can do many of those type of research studies using existing data collected for other purposes, but you reuse it for answering some research questions with regard to the policy or assess, health economics. That I'm here listing research that are done with the primary intention of gathering data or biospecimen sample to answer research question that you are interested in. Those are disparate few types. And vast majority of the human health research studies that involves primary data or sample acquisition and analyzing them fall in two categories. One is observational, mean you observe what's happening in human population, but you don't actively intervene to do anything, okay? Whatever happening, the way you let the people live their life, and in the course of living their life, whatever is happening to them, you try to capture information to capture the way they live their life and learn from there what is helping them, what is not helping them in terms of their health status. So those fall in the observational studies, and those could be different types of terminology are there. And I've listed them here just so you are exposed to the terminology. I will not go into details any of them, but I will make a point that there is a second category of research, which is called interventional, which you probably know. And I listed the dominant type of interventional research. This is where you, as an investigator or a researcher, you do something to change the way individuals are living their lives. And by making that intervention, you can evaluate whether that intervention is making something good or bad for them, okay? So observational study, you don't do anything. Interventional study, you do something with an intention of changing their health outcome and evaluate that. And the gold standard of that mechanism is called randomized clinical trial, which many of you already know by now. And in terms of, it doesn't apply always 100% cases, but most, in a generic sense, I can say the weight of the evidence based on which you can make a conclusion is usually in this order. In other words, a study done doing purely in the laboratory to understand the mechanism of something. Based on that, what you can make a decision in terms of treating a patient by a physician or making a concrete policy about who should be treated by a treatment guideline. When you do those kind of decision making, usually the weight of evidence is higher, much higher as you go down. And the best possible treatment study you can do is a randomized clinical trial, where you randomly assign certain individual of a given disease with a certain treatment and randomly assign the rest of the individuals on something else, and you can evaluate the effectiveness of that in treatment. And if based on the results of randomized trial, you can make decisions about treatment guideline, policy, and other aspects. So I just wanted to bring this to your attention again, in this context, because I'm going to show you some examples, and then I'm going to show you example of not those, but this one particularly. And so you know, this is the gold standard format of biomedical research, from where the weight of the evidence is of the best quality you can rely on most, and then you can make decision based on that. So with that background, now I'm introducing what is this. We established 21 years ago, back in 2000, year 2000, when I was at Columbia University. I was a faculty there. So we call it Bangladesh Population Health Laboratory. And subsequently in 2006, I moved to University of Chicago. So we have been pursuing this line of research there. So essentially, what we established, so-called, we call it Population Health Laboratory. What we mean by is that we chose one geographic area. There was 500,000 people live there. And from there, we carefully, first of all, we did a population census of the whole population. Then we carefully selected about 35,000 people and their children, and carefully collected various types of data, biological specimens, and we have been following them over time. And we are also providing clinical care to all of these 35,000 people and their family members since 2000 up until now. And that's what we have been following. So this is we call it Population Health Laboratory. And within this context, we conduct a variety of observational studies and surveys, as I just showed you before, meaning variety of this kind of studies, as well as this kind of studies, laboratory mechanistic studies, and interventional study or randomized trial, which one I'm going to just collect you. So we are conducting a variety of different types of research within this setting, and depending on the research question, and depending on the disease, depending on the resources we have, we do various research studies. And all the way from mechanistic studies to observational to randomized trial to precision medicine research, I'm going to, and then even policy economic research. So that's the setting where we have been conducting variety studies, and that I mentioned at the outset, our institute has been focusing on now on the global health side. And we do very similar population health laboratory here in Chicago. I will not have time to go to those, but we also have this population health laboratory built in south side of Chicago and in very large populations. And we are conducting this kind of research in a different context, in different setting, but the idea is same, okay? Bringing precision medicine and population and public health together so that we can get the best possible healthcare solutions, whether it's a prevention or treatment or survivorship, for everybody in the population. And that's what we have been doing. So coming back to Bangladesh side, this is that particular area where 500,000 people live. And I'm showing you, this is a map of every single drinking water tube wells, every single wells that are serving drinking water, primary drinking water source for this 500,000 people. We have tested that over time, starting from 2000 and in the subsequent several years. And these are the concentration of arsenic in those drinking waters, as you can see. So just to have a spatial geographic map, GPS map of that our study area, okay? Within that, these are these 35,000 cohort member which we are studying more in-depth longitudinally over time that I showed you before, okay? This red sign is a primary community hospital we established in this study area that provides healthcare, primary basic healthcare to all of those 35,000 individuals and their family members, okay? So that's the setting. Over time, we have been I showed you arsenic because that's what has been a major environmental health crisis there. That's why I'm saying the context that first. But we are also doing a variety of other research within that. For example, for the last 5 years, we have been focusing our work in this area in the same framework on air pollution. So this is more of a zoomed map of this particular area. okay, where our primarily our research participants live is, but in this case, every single household in this area, we are putting a air quality monitor, and that is measuring many different types of air pollutants, and because the instrument that we use, but and one dominant parameter there is called particulate matter. Particulate matter 2.5 means the size of that particulate matter in the air that we cannot see, we just breathe in. That's less than 2.5 micrometer in diameter. And those kind of small particulate matter, those are air pollutants in the air. We cannot see it. And if we breathe in, it goes straight to our lungs, to the small bronchiole, and it's small enough that it diffuses it from the air through the alveolar cells to the alveolar capillaries in the bloodstream, and it goes all over the body. Okay, so that's why these particulate matters are important, because this goes straight from air to our bloodstream as we breathe in. And then depending on what's in this small molecule, depending on the content of it, it causes a variety of health problems. So that's why air pollution is a major problem. Of course, all over the world, particularly developing country where industrialization is happening, less policy restriction, but people are less aware of it. And on top of that, this particular population, there is also, they use solid fuel for their cooking. So there's one additional source of, in addition to industrial pollution, that's another source. So that is causing this problem. So anyway, I just wanted to give you a flavor of, again, in the population health laboratory context, meaning we study everybody in the population. Okay, so 50 microgram per liter of air, okay? And as you can see, these are the numbers it's showing. These two categories, this green and light blue, this goes from 0 to 12, 13 to 15. Okay, this is the picture of the community hospital that we have there that I showed you before. This dot, that's in the which provide healthcare to all of these people, and that's the setting. In the course of provision of healthcare, everybody, not only we collect data from their household, go to their homes, and they come to our community hospital. They get healthcare. All of this data we. This one just showed that, this is an exercise we did almost 17 years ago. First, we documented that in Bangladesh, given this massive arsenic concentration in drinking water, the number of cancers that is expected to be excess due to arsenic on top of what they are going to have anyway is almost double. As you can see, for bladder cancer, liver cancer, lung cancer, you can see that the number of the size of the red bar is more, at least equal, if not bigger than the gray bar. Means the excess cancer that's happening, expected to be happening in this population is alarmingly high. So because of that, we have been conducting variety of studies there, including a study we started doing focused on skin cancer. This is the picture of some of the skin lesions and skin tumor and cancers that's happening in this population because of arsenic. And we started doing a number of research studies. One that I'm going to show you quickly is this we call it Bangladesh Vitamin E and Selenium trial. In short, it's called a BEST trial. So this is coming back to that example, as I showed you before, this is a randomized clinical trial because we are intervening the participants, okay? And we are intervening with what? With vitamin E and selenium. Why? Because we believe, and I'm going to show you a second, that vitamin E and selenium, they are antioxidants, and arsenic causes cancer through a mechanism that by producing reactive oxygen species in the tissues. Those reactive oxygen species that are produced by arsenic, those are mutagenic, meaning they change the DNA sequences. So they introduce mutations in certain part of DNA that may lead to mutation that happen to be in an oncogene or tumor suppressor gene. Those are responsible for development of cancer. And by doing that, arsenic leads to cancer development. That's what I just showed you. That's why there's excess cancer happening. And because of that, we thought, and there are some, based on some our a number of studies, we have observational studies which found that vitamin E and selenium, we know that they are antioxidants, and they counter the effect of arsenic. And we thought if we can intervene these people who are at higher risk of cancer, particularly in this case, skin cancer we picked as to study because that's the commonest. Can we prevent skin cancer by intervening them vitamin E and selenium, especially this population who may be deficient a little bit of nutritionally, okay? So this is a little bit of design of the study. I will not go into that. Essentially point is there are about 7,000 people who we have enrolled in this trial, and we have divided them into 4 groups. One group, they received selenium, particularly L-selenomethionine 200 microgram per day. And then second group, we gave vitamin E, specifically alpha tocopherol acetate 100 milligram daily. Third group, third group received both vitamin E and selenium. And fourth group, nothing, okay? But they received a placebo, a dummy pill, which the participants will not know whether, how it looks like. So, and we designed this trial as a double-blind, randomized control clinical trial, meaning double-blind means neither myself as a principal investigator or any of the research staff or the physicians, none of us know who's getting what. Of course, the participants don't know what they are getting. So, but we randomly assigning them to receive this 4 different types of treatment groups. And over time, as a 6-year period, we have given everybody same 1 pill a day. And after 6 years, within the 6-year period, we wanted to see who develops skin cancer, who do not, and who dies in this population and who do not. And then we will evaluate whether selenium and vitamin E is preventing this cancer development or death. And that's what the research study is. And this is called the gold standard type of study based on which the weight of evidence is of highest quality. So you can make a decision. If this trial shows that vitamin E prevents skin cancer, then I will feel confident, okay, now we can treat these individuals with vitamin E. Or if this reduces death, then we can say that, okay, we can recommend to the government or international agency to make even a policy because we feel confident these are good for prevention of mortality and cancer, and they don't have much side effect. In other words, the benefit outweighs the, if there is any side effect, and then we can make a recommendation, okay? So that's the context. I'm just quickly go over to show you that, let me just see quickly what time it is. Yeah, I'll come to that question. I see a question in the chat. Of course, that's the first thing, if the removal of the arsenic from the drinking water is the dominant method, but unfortunately, just to quickly answer to that, once individuals get chronically exposed to arsenic, in this case in Bangladesh population, they have been, I didn't go into the details, these people have been drinking water with arsenic for many, many years, starting from 1970s, 80s. So once you drink water with high arsenic, once you get exposed to, even if you drink arsenic-free water for the rest of your life, throughout your life, your risk of getting cancer and mortality will be higher no matter what. The same as smoking. Once you smoke for 10, 20 years, your risk of dying from smoking-related or getting smoking-related diseases and dying from it will remain high throughout your life. It will go down once you stop smoking, but it stays there. Same with arsenic. So it will be there even after arsenic exposure is removed. So you have to find solution. How can you reduce their death once you give, in addition to giving arsenic-free water, what else you can do? That's why we're doing these studies, just to answer that. So these are some of the supporting evidence, as I said, from observational studies, as I showed you in the before, meaning we did many of these observational studies, including one small pilot randomized trial to see that selenium and vitamin E, whether they can help countering the molecular effect of arsenic in the human tissues in this population. Once we felt confident that it does, then we designed that trial, as I just showed you, the best trial, okay? And now coming to what did we find? After this, we spent almost 10 years of with about 50 to 70 research staff to conduct this trial after all this supporting evidence is done. And then what did we find? Okay, so this is the 6 years. Those 7,000 people there, we gave them a pill every, as I mentioned, every single day. So one important element of treatment clinical trials efficacy is dependent on how well the individuals, it keeps shifting, how well the individuals adhere to the treatment that they're supposed to do. If they don't take what we want them to take, then obviously we don't see the benefit of it. So this is a very important measure to the treatment compliance before you can evaluate the efficacy of the treatment. So as you can see, these are two ways we can evaluate efficacy. One is every single pill we gave in a bottle for 6 weeks supply. When the bottle is replenished, we counted how many pills are left over in the bottle. And that's why, as you can see, over 90% of the pills that we have been given over every single 6 weeks for 6 years, they have taken it. So we felt good. Okay, so participants have been compliant. And also we asked participants a question about after every 6 weeks that have you taken the pill? Okay, and if they have, how many you didn't have? So they also self-reported, okay, I missed 3 days, okay. And if you look at that answers, you also see that compliance have been throughout the 6-year period outstanding. And that's not enough. We have to measure objectively. So and then what else we did? We also measured their blood level of selenium and vitamin E before we started treatment at baseline and after 2 years of intervention, okay? And as you can see, in the 4 treatment groups, the placebo, those who didn't get anything, their levels of vitamin E, or this is selenium, this is alpha tocopherol, those two didn't change. We also measured as a control measure gamma tocopherol. We didn't give them gamma tocopherol, but we measured that's another analog of vitamin E, which had some relationship with, we also measured that. Anyway, point is showing that in placebo, as you expect, it didn't change much, these two that we intervened with. In the selenium treated group, selenium has almost skyrocketed, became 5-fold after we gave them, over the 2-year period, but it didn't in the, for the over 2 year, the alpha tocopherol. But in the vitamin E group, again, selenium didn't change much. If at all, it went down a little bit, but vitamin alpha tocopherol, again, almost doubled, 70% increase, as you expect, because that's the level you can go. It cannot go, there's a limit how far you can go up. And those who receive combination, again, have both jumped. Both vitamin selenium jumped 130 to 500 microgram per liter, and also alpha tocopherol also jumped in that group. So the point of this showing all of these are key measures before you interpret the evaluation of a treatment trial, how compliant the study participant have been. And you measure subjective, many different measures, including objective measure, as well as many different other subjective measure where could be some error. So point here is these trial participants have been outstanding. They have been very well compliant. And this is coming back to the very first slide I showed you, second slide, the advantages of doing global health research. In this case, the randomized trial I conduct here in Chicago, I do not get this kind of compliance where the treatment trial, longer term cancer prevention trial that we are doing here in this country, is just not feasible for a variety of reasons. So again, this is another, sometimes it's an advantage to do this study in a low resource setting in a population where you have a more bigger trust on the physicians and the researchers and the health system. And because of that trust, and because of their relationship with us, we were able to get this level of compliance. Okay, so coming back to that, this is one example of I'm saying that some certain thing, this research study, if we did it here in this particular one here in the United States, our quality of trials would not be as good as this. So just to give you an example. So this is just showing that point. Now the results of this trial is basically point of that is showing that we did not see, I will not go into the details, HR is called hazard ratio, point of that, if this is significantly more than 1 or less than 1, that means the treatment is making a significant effect. And as you can see, the hazard ratio estimates, as well as their 95% confidence bound, that includes one. Basically, the point is this: the treatment 6-year intervention by vitamin E and selenium did not change their incidence of skin cancer. And this one shows the survival curve for the mortality from all cause as well as cause-specific cancer, cardiovascular mortality, and other mortality. As you can see, no matter how we slice and dice, how we see this y-axis here is the proportion surviving after 6 years, and x-axis is the number of years, year 0, 1, 2, 3, 4. As you can see, over 6-year period, whether we look at the all-cause mortality, total mortality, or cancer-specific mortality, cardiovascular, other, basically vitamin E and selenium in this population 6 years did not make any difference, okay? Even if, contrary to what we thought we would do, it will achieve, and contrary to what we learned from all of this observation studies. So, and this is another way of looking at it. Anyway, so the summary of this part of the study, this trial I wanted to point here is that despite the take-home message here is that what we learned, and also for you to get a message that despite substantial evidence of antioxidants to play antagonistic roles in arsenic-induced diseases and cancers from observational studies, as we have seen, about a dozen studies we did ourselves and others, when we conducted a large-scale, state-of-the-art randomized clinical trial, which is the gold standard of evaluating a treatment, it fails to confirm any beneficial effect of antioxidants, particularly alpha-tocopherol and L-selenomethionine, that we have intervened them with for neither for non-melanoma skin cancer nor for mortality outcomes. Okay, so this is a message that I wanted to keep in your mind, that until when it comes to the treatment, until you make a policy decision, until you have results from a well-conducted randomized trial, it's not the end of it. It's not the end of it. You cannot make major, that's why you will see in the news media, many, often, there are thousands and millions of research studies are published all the time, but every study's results is not the same. I'm not saying that, but there is a quality, there is a weight of the evidence that comes from every single study. Everything you've seen that's in the news, everything is not the same. That's the point. So that's why you will often find contradictory finding, but you have to sieve through all of those and see which one is the good quality research studies for which the message you want to extract and rely on and keep in your head. You have to think of that aspect of it. That's the point. As you grow and become more senior research future giant in the field, this is an introduction to your topic. Second point, let me see how many minutes I have. Don't have much time, so I may not be able to go much, but quickly let me go through, just give you the nutshell of this. So the second study I wanted to cover quickly to give you an exposure. We have been also conducting a variety of artificial intelligence driven methods to see whether we can gain some knowledge that would be beneficial for healthcare in the resource poor setting. And you already know that many different types of artificial intelligence making a huge difference in every field of science and society, including medicine. And we are doing that also both in Chicago and in Bangladesh. But I wanted to give you one quick example that in this case, what we did, there are many different types of artificial intelligence method, and all of the bulk of them are based on a method called neural network. And that's the fundamental framework, like regression analysis in classical statistics. Neural network is that like regression analysis, bread and butter for artificial intelligence methods. And those are neural network based. All of these methods are called deep learning models. Many different types of supervised, unsupervised, and I'm drawing your attention particularly to this particular convolutional neural network based deep learning model. That's the method is used in image analysis. As you see all this facial recognition software that you use there, everything that, and speech recognition, Alexa, the way Alexa is working, the self-driving cars are working. All of these are based on some variant of convolutional neural network-based AI models, deep learning algorithm that is helping you through image analysis in doing all of those. Because this is, that's what it does. It does a good job in, it doesn't matter what kind of image it is. If you can train the methods well, you can get a good solution from the algorithm. So I'm zooming into quickly, skipping this. Basically, we did that in Bangladesh. Obviously, the number of pathologists, especially dermatopathologists, in this case, for example, who can detect skin cancer only in Bangladesh, there are hardly one we have right now, currently for a population of almost 160 million people, who is a properly trained dermatopathologist. So this epidemic of skin cancer, many other cancers happening, there are not enough even pathologists who can, throughout the country, who can detect, review these tumors and detect them. So we thought, is there any role for AI by doing image analysis that the skin cancer could be detected by computer algorithm, even in the absence of dermatopathologists, and only a selected subset, which then could be brought to the attention by the expert dermatologists. So we did a study of, in our best trial, there are about 750 biopsies we have done for skin tumors. We have those 750 biopsies, we have them reviewed by our chief of dermatopathology, University of Chicago. He reviewed them all 750 slides using his naked eye review, and he rated them who is cancer. That's what we analyzed those trial efficacy and treatment efficacy, as I showed you. And then we used a convolutional neural network driven deep algorithm model to look at those histopathological images and train the model to see, can it detect them, which is cancer, which is not, and compare that with based on the gold standard, the truth, ground truth, what we call that our pathologist had said, and then compared them in an independent set whether that algorithm can be validating. And this is what we see. And we found essentially, this is, by the way, this was done in US by another group up. So we tried to do similar thing in Bangladesh. As point of is, long story short, this is the process of doing it. I'm not, I don't have time to do it, but basically, long story short, this is the point where I'm going to show. So as you can see, this is the true result. These two slides, this one is the first one. If we see that there are 4 types of skin tumors, one is clearly normal, we call it non-cancer. One is Bowen's disease, or these are called carcinoma in situ. This is the just transition between normal to cancer in early stage of, that's called carcinoma in situ. There are many carcinoma in situ, many different places, but this is skin specific. And this is SCC, squamous cell cancer. BCC is basal cell cancer. These are the 2 types of non-melanoma skin cancer. And then of course there is melanoma, that's another type. So in arsenic exposed population, these are the type of cancer that happen. And we compared the computer predicted algorithm with the pathologist diagnosis. And this is the statistic that is used, which is called receiver operating characteristics driven area under the curve. This value of this range from 0.5 to 1. 0.5 is the 50%. If it is random, an algorithm you're applying to detect something, it has 50% chance. It's like coin. You have a 50% chance of doing it right, if you want to say that it's a normal or cancer. And if it is 100% accurate, then it becomes 1. And as you can see, this particular algorithm that we applied is called attention-based deep neural network, which has an accuracy of almost like over 0.9 for 2 cancer types. And if for the carcinoma in situ, the transition between normal to transition is not so well. But if we combine these 2, because the Bowen's disease for skin doesn't need much treatment. So if you combine those 2 and put them together, then you can see that this discrimination is even better. So basically over 90% of the chance accuracy you get their computer-driven algorithm to detect a skin cancer in this Bangladesh setting that we can achieve. And the idea point is that if we can do this well, this you don't need lot of resources to apply this. You just need a good a person to sit in front of the computer and apply those models in an informative, knowledgeable way. But then if you can do that, this at what point is the key point is that attention-based convolutional neural network driven deep learning algorithm can diagnose non-melanoma skin cancer with high accuracy as compared to expert dermatopathologists, and which we hope open the new opportunity for overcoming limited access to clinical care in low research settings in Bangladesh and other countries. Again, this is just a small example in a specific setting, but the same thing can happen in many other diseases, many other ways. So my point of saying is that over time with this, hopefully this AI-driven tools and technology will be able to play a significant role in solving the healthcare solutions in resource-poor countries, not just in these countries, or the self-driving car or image recognition, but also there is some practical solutions in biomedical field and in resource-poor settings. We can also get some benefit out of it. I'll end here, and maybe I'll take 2-3 minutes of your time if you have any questions now. Sorry for running a few minutes over.
My name's Siam. I am a rising sophomore from Solon, Ohio. My one question is, this was a graphic in the earlier part of the presentation where you showed the different incidence and mortalities of different cancers all across the world. I'm just curious. So I noticed how prostate cancer being the most common cause of cancer, at least among males, when it comes to like incidence rates all across the world. Prostate cancer was addressed across many parts of the world, but comparing that to breast cancer, for breast cancer again being like the common cause of cancer, at least when it comes to incidence for females, there was still a large part of the world where breast cancer had the highest mortality rate when it comes to cancer deaths. So why is that disparity there?
Yeah, very good observation. Okay, thank you. Good point. And there's a lot of complex explanation to that, but simply speaking, that not all cancers, the progression, the biological process of development of cancer, and then progressing further to the point leading to metastasis and then leading to death, that process is not linear. So prostate cancer, it develops if the right context is there, if the genetic predisposition there, if there is other toxins exposure, environment exposure there, then cancer develops fast and often. That's why you see the commonest cancer. But then many of those prostate cancer don't progress, particularly early stage. There is a type of prostate cancer that called carcinoma in situ inversion in prostate also, another. They don't then progress as rapidly, whereas breast cancer, a larger fraction of them keeps progressing. And so that's some biology. And then there is other factors of healthcare access. The treatment of prostate cancer, treatment of breast cancer are different. And the access to those, whether it's chemotherapy or the surgical resections or radiation therapy, all of those factors are also play a role here, depending on which country has those access or not. Again, as I mentioned, the pathology, someone who can diagnose them. If you don't, okay. So all of those factors, biology, healthcare access, and the population of that country, their health-seeking behavior, what their knowledge of them, all of those play a role in those. So some of those are making this difference. Why breast cancer is, the difference is what you said, as what you just observed. Good observation. Yeah.
Okay, thank you.
Mm-hmm.
Yeah, so in the first study you mentioned, like I completely expected it to be successful, but I understand the point that you're saying, like you should do your research on like which studies are accurate and like which ones to focus on. And so what's your recommendation for like finding good studies or like reliable studies?
Yeah, so it depends on the questions you are asking for. So if it is the question is, just to simplify this point of saying, if the question is, you want to know an intervention of what can cure a disease, or what is something a physician or health policy person can do to reduce the health problem. If we're talking about a treatment, then randomized trial is the gold standard. You have to look for what is evident from a randomized trial in terms of an intervention that is effective or not. If you're looking for evidence for an intervention, whether it's effective or not, then randomized trial is the gold standard. For other setting is different. Many setting you cannot do randomized trial. When you look at when you are looking at what is harmful, okay, then randomized trial cannot be even done ethically. You cannot intervene someone with tobacco. Okay, you smoke, let's see whether how bad is smoking. Okay, so harmful elements you have to evaluate other ways, observational studies. But if it's something beneficial thing you want to intervene with, then randomized clinical trial is something you will be looking for, and evidence from there, that's what you will be looking for to making, your decision-making purposes. Does it make sense? Okay.
Hi, Dr. Ahsan. I wanted to thank you for your presentation. It was really detailed and I learned a lot. I wanted to ask about, so like Bangladesh is kind of a homogeneous country, but like you said that you were kind of doing a similar study, so like the population health laboratory in Chicago. Like I wanted to ask how the factor of like race kind of changed the results and like your views on that. So yeah.
Yeah. So a very good point. Obviously, Bangladesh is relatively homogeneous country population with regards to ethnic background. So in US, particularly in Chicago, that is another major dominant factor we have to pay attention in addition to everything else. So it's not that it's a biasing the result. We just have to pay attention to one more major factor that is a dominant cause of healthcare access and disease. We just have to take that into consideration as we're designing and conducting and implementing and interpreting this study. And there are many different ways to do that. That's all I'm saying. Yeah. So you just have to be cognizant about the context.
Thank you, Dr. Ahsan, for your presentation. I'm Sean, and I'm a rising senior. So my question was, so you stated earlier in your presentation that these studies take time, lots of time to see the results of the effects of the pollutants in the blood and stuff like that. But have they considered maybe looking at the specific gravity of urine or water, the drinking water, of, I don't know, even animals in the area, the cattle in the area, to see if this can maybe speed up the process?
Yeah, the answer is yes. There are many different parameters I didn't show here, that are relevant for this research, including specific gravity and other measures for the urine, water, and those you have to take. That comes into some of the laboratory measures. When you look at the urinary concentration of arsenic and you want to take that into consideration, you want to adjust that based on the specific gravity of the urine and the hydration status, their creatinine, kidney function of the individuals. Many other factors you have to consider when you interpret blood level, urinary level of metals or other parameters. So yes, those are taken into consideration.